Good morning for those in Western time zones. Good afternoon for those of us in Central and Eastern time zones. This hearing will now come to order. As this hearing is fully virtual, we must address a few housekeeping matters. For today's hearing, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you've not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there's a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time has almost expired. When your time has expired, the clock will turn red and I will begin to recognize the next member. In terms of the speaking order, we will begin with the chair and ranking member. Then members present at the time the hearing was called to order will be recognized in the order of seniority. And finally, members not present at the time the hearing was called to order in their order of arrival. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any time during our hearings or markups. That email address has been provided in advance to your staff. Good afternoon and welcome to today's hearing. Following last week's hearing with FDA Commissioner Dr. Robert Califf, we are again looking at the infant formula recall, the nationwide formula shortage, and the impact it is having on infants, kids, and families. In the past week, both Congress and the administration have moved swiftly to address the formula shortage crisis. Last week, Congress passed 2 bills which would expedite the return of safe formula to store shelves and expand the options that our most vulnerable families have when purchasing formula through the Supplemental Nutrition Program for women, infants, and children. We must continue to press forward with oversight of the FDA, as well as get the FDA the much needed resources to meet the needs of the crisis and allow them to increase the capacity to inspect and ensure the safety of the formula supply, both in the US and as we bring in emergency supplies from abroad. We need the funds to get this done. The administration also moved quickly by invoking the Defense Production Act to streamline the supply lines for existing safe formula to get to American shelves, even from overseas suppliers. The administration is also using the Defense Production Act to make sure that our domestic manufacturers have access to the ingredients they need to ramp up production of the formula. Today's hearing is important because we need to fully understand the impact of a shortage of formula supply on our country. As we will hear from today's witnesses, formula supply does not just impact infants. It strains our grocery chains, and families in different communities face different challenges. Without information, worry takes over and leads to counterproductive behavior like hoarding, and it creates fertile ground for bad actors, creating fake formula and sellers and price gougers. For that, I am pleased to introduce and welcome our panel of witnesses. Sarah Chamberlain, who is Executive Director of the National PKU News. Michael Gay, owner and manager of Food Fresh in Claxton, Georgia, representing the National Grocers Association. Ginger Carney, Director of Clinical Nutrition at St. Jude's Children's Research Hospital. And Brian Ronholm, Director of Food Policy at Consumer Reports. Thank you all so much for being here. Our first witness is Sarah Chamberlain, a mother whose 8-year-old daughter relies on special formula for about 70% of her nutrition. It is a reminder that formula is not just for infants and that specialty formula is life-sustaining and can be needed for lifelong nutrition as a medical treatment for certain conditions. Simply put, there are no alternatives. I'm also glad we will hear from Michael Gay, representing the National Grocers Association. Grocers are very much on the front lines. They are on the ground and can see a community's needs in real time. I'm very concerned about our rural communities that often have only one grocery store, leaving people with little choice but to travel significant distances for formula. I'm also looking forward to hearing from our other witnesses, Ginger Carney, who is the Director of Clinical Nutrition at St. Jude's Children's Research Hospital, Carney and Brian Ronholm, Director of Food Policy at Consumer Reports, to gain insight from their expert knowledge and their decades of experience. Both Abbott and FDA share in the blame for the situation we are in right now. Whereas Abbott failed the public by not maintaining a safe manufacturing site to produce this vital nutritional resource, the FDA did not live up to expectations, inspecting and responding to concerns about the manufacturing process and safety. Because of these circumstances, we find ourselves climbing out of a crisis which has harmed children and understandably worried families. I'm glad this committee will give voice to those stories today. I again want to thank our witnesses for being here. We know how busy you are. And on behalf of the committee, we are grateful that you've taken the time to speak with us today. Now I'd like to ask our distinguished ranking member, Dr. Harris, if he has any opening remarks, and if so, I would like to recognize him at this time for those remarks. Mr. Harris, you are now recognized.
Thank you, Chairman Bishop, and I'd like to welcome our witnesses to the hearing today. I appreciate you all sharing your experiences with us as our country remains in the middle of an infant formula supply crisis. Like parents across America, I'm frustrated by the Biden administration lack of urgency prior to last week to address this issue. Supply challenges started last fall. On November 12, 2021, WSOC in Concord, North Carolina reported that Dr. Margaret Quinlan, a UNC Charlotte professor, said, quote, "Our country is failing us if they're not seeing this as something that needs to be a priority." CNN also had a headline a few days later, quote, "Baby formula is getting harder to find." But rather than tackle this looming crisis, the Biden administration chose to work on the holiday gift supply chain instead. The formula shortages cited in national and state media outlets last fall were then exacerbated with the Abbott recall of infant formula and the facility closing in February. Again, CNN had a headline in February, "Baby formula shortage has some families scrambling." And when did the administration finally decide to take action? Last week. The administration should have made it a priority to address supply chain shortages long before now. Instead, parents and caregivers are facing unimaginable stress and anxiety as they search for formula to feed their babies. After one of the largest formula manufacturing facilities in the US closed, the administration should have been working around the clock to get this plant safely back online as quickly as possible. 3 months have passed, the facility remains idle. I believe this crisis could have been averted if the administration had acted on supply chain issues last fall. Existing funding and authorities were at their disposal and could have been utilized to address this predictable situation much more quickly, just as Republicans suggested, and just as the administration did this past weekend by having formula flown in from overseas. None of these actions needed more money or more authority from Congress. It would have just taken leadership and initiative from the administration. It's disappointing we find ourselves in this situation when the alarms were sounding months ago. But again, I want to thank our witnesses for joining us today to share their experience and the impacts they've seen from this crisis. I look forward to today's discussion. Thank you, Mr. Chairman, and I yield back.
Thank you, Dr. Harris. We are very fortunate to have the full committee chair with us, and I would now yield to Chairwoman DeLaura for any opening remarks that she may have. Chairwoman DeLaura, who has been very, very passionate on this issue, and we certainly look forward to hearing your remarks.
Thank you very, very much, Mr. Chairman. And let me just congratulate you on yesterday's election. It's great to see you. And as we try to move forward, I want to say a thank you both to you and to the acting ranking member, Mr. Harris, for holding what is an important hearing. And I would particularly thank our witnesses this afternoon for testifying on the infant formula crisis in our country. We are all absolutely shocked by the crisis that's facing America's babies and their moms and dads, a crisis of both safety and supply. At least 2 babies died and several others were hospitalized after consuming Abbott's infant formula. And for the past several months, parents all over the country have been struggling to find safe formula to feed their babies. On Monday, I held a roundtable in my district and heard heartbreaking stories of already vulnerable parents scrambling to feed their babies. They reiterated how formula that has been historically difficult to find is now nearly non-existent on shelves. Moms and their advocates fear that babies may become undernourished and develop enduring health problems. One 19-year-old mother told me that despite relying on formula to feed her 3-month-old baby, she was denied WIC and was told she should just breastfeed. Like far too many others, she is unable to produce nourishing breast milk and relies on community support to feed her baby. And now she is struggling to find any baby formula at all. Also heard from grandmothers who were taking care of their grandchildren and having to take them to the emergency room with vomiting and with diarrhea and linked directly to the formula that they were taking, Abbott's formula. Another was a mom of a baby who, after eating Abbott's contaminated formula, which was later on the recall list, was sick for 8 days in and out of the hospital and told that her son merely had a virus. This formula stayed on shelves much longer than it should have. The stories I have heard were absolutely unacceptable, and these same stories are happening in big cities, small towns, rural communities all over our nation. Parents need more help. As you know, in September 2021, FDA inspectors conducted a routine inspection of an Abbott nutrition facility where suspicions of wrongdoing were already present. On October 20, someone working at the facility submitted a whistleblower report to the FDA, unveiling a damning list of allegations, asserting that the company lied, cut corners, falsified records to cover up their misdoings. Not until late December did the FDA interview the whistleblower, and then not until late January was the plant inspected in person. Abbott then issued the recall in February, some 4 months later. In March, I requested an HHS Office of Inspector General report to look into the tragedy. And then I got a hold of a whistleblower report and submitted it for the record to make it public. Last week, I introduced and the House passed a $28 million supplemental appropriations bill to give the FDA the resources it needs to address the current shortage. That is mostly personnel to be able to deal with inspecting facilities, and also to review the infant formula applications that are coming in. They do not have the personnel. I have no problem faulting the FDA for what they have done, but we cannot compound the problem by not providing resources at this moment for much needed inspection personnel and infant application submission reviewers in order that we know that the products that are coming in are safe. And to not wanting to move forward on that $28 million really says a lot about people and their care about what is going on in this in this space. At a hearing last week, the subcommittee questioned the FDA Commissioner Califf on FDA's incredibly slow response, which led to Abbott products staying on the shelves longer than they should have and potentially putting even more babies at risk. In the long term, the FDA must address its longstanding structural issues. I believe we must establish a deputy commissioner for food safety within the FDA, someone with extensive knowledge, background, and credentials in food safety. This week, I will introduce the Keep Infant Formula Safe and on the Shelves Act, which addresses the root cause of the crisis, including product safety and supply infrastructure. And I'm moving to deal with the issue of consolidation in the industry, which has only allows for 4 major suppliers. Thereby, if one is gone, we have this shortage that's been created. Because unfortunately, then none of this is new. We recently learned that in 2014, the formula industry deliberately and successfully tried to weaken bacteria testing safety standards. The FDA had proposed rules, a protocol that year to increase the regular safety inspections of infant formula manufacturing facilities to prevent the contamination, the specific contamination that we are discussing today. This very crisis is now facing our nation's babies. And while the FDA was slow to respond, and I'm going to make a distinction between the FDA and the Biden administration, because the Biden administration moved quickly, as did USDA, with dealing with waivers for WIC recipients to be able to purchase another product other than the Abbott product. But the administration, through Operation Fly Formula and the invocation of the Defense Production Act, has secured infant formula from FDA-regulated facilities to be flown in and imported quickly to meet this urgent need. I will follow up to make sure that they are FDA-related approved facilities. I am concerned about FDA guidelines, which say that we can entertain other facilities that do not meet the FDA standards. The first batch of that formula arrived quickly. It arrived this week in Indianapolis. More is coming. There's a shipment that arrives at Dulles today. The administration is addressing the critical supply issue while ensuring that the product being manufactured is safe and healthy for our babies. In the wealthiest nation in the world, babies should not be at risk of going hungry. Parents should not have to play a guessing game and wonder if they are feeding their babies something that is safe. Unfortunately, that is where corporate greed, consolidation of formula production into just 4 major companies, and a lack of proper oversight have led us. I hope that our witnesses can help us further understand the impact that this shortage has had on babies and their parents, and what else we can do to prevent this from happening again. I want to say a thank you to the chairman, who really has moved, speaking about moving quickly, moved very quickly on addressing this issue and calling hearings in order to address it. And also thank the acting ranking member. I yield back.
Thank you very much, Mr. Laura. I don't believe the full committee ranking member is present with us, or I would ordinarily recognize her at this time. But in her absence, I will now recognize our distinguished guests for 5 minutes for brief oral statements, and then we will proceed with questions. Without objection, each of your entire written testimonies will be included in the record. So if you could summarize your testimony within the 5 minutes, we would most appreciate that. Ms. Chamberlain, welcome, and you are now recognized. Please proceed.
Good afternoon, Madam Chairwoman, Chairman Bishop, ranking members Granger and Harris, and members of the subcommittee. Thank you for inviting me to testify. My name is Sarah Chamberlain, and my younger daughter has the genetic metabolic disorder phenylketonuria, better known as PKU. I am here to share the profound effects of the formula crisis on our family and those like us. There are very few exactly like us. Of the 3.5 million babies born in the US each year, only about 275 are diagnosed with PKU. But let me be clear, this crisis is not limited to infants. There are many others who rely on formula as their lifeline from infancy through adulthood, including thousands with inborn errors of metabolism, GI, and allergic disorders. I hope my testimony will amplify their voices. People with PKU can't metabolize one of the amino acids in protein, which then builds up and acts as a neurotoxin. Babies with PKU are born healthy and within months, if untreated, become irreversibly brain damaged. Newborn screening now allows us to detect and begin to treat PKU almost immediately after birth, ensuring normal or near normal health outcomes for these individuals, provided they have lifelong access to medical formula. My daughter Izzy was diagnosed at 6 days old, and she'll be 9 in August. She's limited to a diet of 5 grams of protein from food per day, which is the equivalent of about 1 slice of American cheese. The rest of her nutrition is provided by an Abbott amino acid formula that was not part of the recall. To Izzy, her milk, as she calls it, is her life. It has sustained her since she was an infant, and she knows it. Her health all comes down to the formula. It's essential, it's expensive, it's inconvenient, it tastes awful, but it's what allows her to live a full life, playing softball, learning fractions, and taking jazz dance every Friday. She's relied on it her entire life, and suddenly she can't rely on it. That's why I'm here today. When the Abbott plant was closed in February, we knew we couldn't risk running out of formula, and that we'd have to transition her to a new brand slowly. Every formula has a very distinct taste. To me, Izzy's taste like nickels dissolved in sugar with a fair dash of salt. And the only reason they are tolerable is because they are necessary and because patients get used to them over years. By early April, we were at half new, half old formula, which is right about when we heard that the new formula we were transitioning her to was on back order. So what are we supposed to do now? We are not alone in our distress. A friend in Louisiana had to ration the formula her daughter gets for a similar disorder. The video she sent me of her usually vibrant, active 12-year-old curled in the fetal position, crying, is heartbreaking. Last week, 2 children with short bowel syndrome were hospitalized because without the specialty formula, the only way to keep them alive is IV nutrition. A friend in her 40s with PKU who was without formula wrote, "I am a wife and mother. I'm exhausted. I'm having constant migraine headaches and memory issues. I am overwhelmed and emotionally fragile. I am malnourished." The message from our community, in short, is this: we are not okay. Chairwoman DeLauro has said that, quote, parents should not have to choose between the supply of product and food safety. That is unconscionable. I could not agree more. But in mid-March, the FDA said that patients considering using Abbott metabolic products manufactured at Sturgis between January and March should, quote, consult with their healthcare provider in considering whether the benefit of consuming such products outweighs the potential risk of bacterial infection. The consequences of inadequate medical nutrition are so grave that we really have no choice. My daughter Izzy does not have a choice. Going without her formula would mean temporary disability. It would mean missing the end of her softball season, not mastering fractions, and never perfecting her jazz dance routine for her performance next month. Long-term, it would mean permanent brain damage. For people with other similar disorders, it could mean coma and death. I deeply appreciate the work of the committee to increase immediate supply and demand accountability from the FDA to avoid future crises. As the immediate shortage recedes, thanks to this work and the work of your congressional colleagues and the administration, we must remember that supply is not the same thing as access. In the US today, thousands face huge bills for medical nutrition, the very formula we're discussing today that their insurance refuses to cover, and this has disastrous consequences for their health. The Medical Nutrition Equity Act, HR 3783 and S 2013, provides for insurance coverage for these formulas as essential medical treatments. It is critical that you pass the MNEA this year to ensure that everyone has access to the formulas that you are all working so hard to resupply. We need your help. We are not okay. Thank you for your time and consideration today.
Thank you, Ms. Chamberlain. Mr. Gay, you are now recognized for 5 minutes. You may begin.
Good afternoon, Chairman Bishop, Ranking Member Harris, and members of the Agricultural Appropriations Subcommittee. My name is Michael Gay, and I currently manage Food Fresh, an independent, locally owned grocery store in Claxton, Georgia. It's an honor and privilege to speak with you today. I'm testifying on behalf of the National Grocers Association, the trade association representing the independent grocery stores. My store, Food Fresh, is the only grocery store in Evans County. We work very hard every day to make our community better and our store conditions wonderful. The formula shortage has hit our community hard. Moms and families are worried about where their child's next meal will come from. I've had to put limits on formula that customers can purchase in my store. This is heartbreaking to do when so many families are in such great need. My managers have had to personally manage formula stock in my stores because the demand has been so great. I had 7 phone calls just yesterday asking if we had a specific type of formula in the store. When I told most of the moms that the formula they were asking for was not available, but I did have it in a different brand, they were very scared to switch because they didn't understand that the formulas are very, very similar. These are examples of what I've seen happening in my store. I'd like to share a little bit about what the members of NGA are experiencing. In a survey of its members, NGA found that most stores are dealing with significant formula shortages. The vast majority are unable to access specialty formulas. They are receiving inconsistent information from state WIC agencies, and customers are panic buying. These stories are all very important context for what I believe is critical to recognize, the role that WIC is playing in this shortage. WIC purchases account for more than half of the formula sold in the United States. Therefore, WIC is ever present in the infant formula discussions to retailers. WIC is a central program for families in my community. It provides supplemental nutrition to moms, babies, kids, and we are honored to be able to provide this program. WIC is not a moneymaker for retailers. In fact, it's the opposite. Many stores actually lose money as WIC vendors, but it is an important community service, and we participate to ensure our families get the resources they need to raise healthy kids and future leaders. Independent community grocers play an essential role as the private partners in the public-private partnership of WIC. But as it exists today, WIC is very burdensome for retailers to offer this program. I'm going to share a few opportunities for improvement to consider avoiding future disruptions in WIC products like infant formula. First, WIC's rigid rules have made it difficult for the program to be responsive to critical shortages throughout the pandemic and now during the formula crisis. Substitutions may be easily available when situations like this arise. The emergency waivers instituted by the USDA during the pandemic have provided flexibility in some states, but those waivers were only available because of the pandemic. To prevent this issue from happening in the future, Congress should allow WIC vendors operating during severe supply shortages, disasters, or public health emergencies, areas to automatically substitute limited to WIC approved products impacted by supply chain disruptions. The USDA should direct states to include product substitutions for WIC in their emergency preparedness plans. These changes would have allowed families to immediately switch to another formula in states with shortages, allowing for a smooth continuation of feeding infants. Secondly, there is a significant need for USDA to examine the long-term effects of cost containment, competitiveness, and peer grouping formulas for WIC vendors. States operate a peer group system to monitor vendor prices and determine reimbursements are cost competitive. These cost containment measures have led to reduced retail reimbursement and reduced retailer participation in the program, leading to fewer locations for families to access formula. Additionally, the WIC infant formula cost containment measures have led to extreme consolidation in the formula marketplace, leaving it highly vulnerable to supply disruptions like we are experiencing now. These contracting policies must be reviewed to ensure future food security of the nation's babies and families. Finally, the FTC announced they are launching an inquiry into the ongoing shortage of infant formula. NGA supports getting to the bottom of this issue to ensure that it never happens again. In conclusion, we want to work to maintain our strong existing public-private partnership with the WIC program and continue to serve our rural and urban families. We all know that infant formula is a necessity for babies to grow and thrive. Let's all work together to get these babies fed and ensure that this never happens again. Thank you all for the opportunity to discuss this important issue today, and I look forward to any questions you may have.
Thank you very much, Mr. Gay. Ms. Carney, you are now recognized.
Thank you, and good afternoon, Chairs DeLauro and Bishop and Ranking Member Harris, committee members, and my fellow distinguished panelists. I'm honored to have the opportunity to speak before you today. My name is Ginger Carney. I'm a registered dietitian nutritionist, an international board certified lactation consultant, and director of clinical nutrition and lactation services for St. Jude Children's Research Hospital in Memphis, Tennessee. I'm here today on behalf of the Academy of Nutrition and Dietetics, which represents more than 112,000 nutritional professionals. As the immediate past president of the Tennessee Academy of Nutrition and Dietetics, I'm prepared to give you a sense of how this crisis is impacting families across the country. No child should face hunger because of safety and supply shortages. Since February 2022, dietitians have been working around the clock to determine appropriate and safe formula alternatives for patients impacted by the current shortage. I have experienced the devastation the formula supply chain disruption has placed on so many families, even in my own hometown. In my role in a pediatric research hospital, we have experienced shortages in our enteral feeding formulas, or formulas provided through a tube for those children who cannot or will not eat enough to sustain them. Many of our patients are children with cancer who cannot tolerate certain foods because their digestive systems have been compromised by chemotherapy and radiation, causing them to rely on specialized formula for their nutrition needs. The clinical dietitians on my staff have had to draw on their extensive expertise to recommend the appropriate tube feeding formulas to provide optimal nutrition support while monitoring tolerance in these children that we serve here at St. Jude. Dietitians around the country can spend hours on the phone every day speaking with vendors to try to find formula for their patients. One colleague of mine in Miami, Florida, reported that parents will file prescriptions to pharmacies, but it may take up to 1 month before a shipment is received, and then there's no guarantee that an ongoing supply of formula will be there. Recently in Memphis, 2 children were admitted to our local pediatric hospital with dehydration caused by intolerance to a formula which had been substituted for their regular specialized formula. Caregivers are at their wits' end and feel that they must find something to feed their children. When an infant is hungry or a child is dependent on a specialized feeding, it can be life-threatening when these needed formulas are not available. In February 2022, a colleague in Florida met with first-time parents of a set of premature 10-month-old twins in her clinic. At the time of this visit, she observed that the babies were behind developmentally and not yet able to eat solid foods. So it was recommended that they continue their hypoallergenic formula to meet 100% of their nutritional needs. When the formula became unavailable, the parents began giving the babies almond milk, thinking this was an appropriate substitution. The switch to almond milk caused a reduction in the baby's calorie intake by nearly 60%. The babies eventually became lethargic and malnourished, leading to an emergency hospital admission. Imagine having to worry that you might not be able to keep your baby fed as your last can of formula is almost empty. Parents are driving for hours to nearby towns to find formula, and many families are not even able to do this given financial or geographic limitations. So this crisis is disproportionately impacting low-income and rural families. My WIC colleagues in Louisiana and Tennessee have similar experiences fielding phone calls from panicked caregivers. Some WIC dietitians are even riding around their cities to take pictures of store shelves to advise their clients which store has the formula that they need in stock. One mother remarked that she was petrified that any formula she found could be contaminated. We appreciate that members of Congress are taking action, but more needs to be done. Our government needs to do more to help new moms establish and maintain breastfeeding, even if they return to work or school. But when that is not possible, there has to be systems set up so that we never experience this kind of formula crisis ever again. Our recommendations include, first, we know the importance of the first 1,000 days of life for long-term health outcomes. We must track the cohort of children experiencing this crisis and determine the short and long-term impact on their medical outcomes and nutrition security. To date, we are not aware of any efforts to formally document this. Second, other developed countries seem to have managed any shortages without significant issues. We must learn from others and revisit the laws and regulations to ensure a stable supply in our country in the future. This includes a thorough examination from production and oversight to access and affordability. And third, insurance companies must reduce the burden required for treatment authorization for non-formulary infant formulas. I want to thank everyone for your time and consideration today, and I'm happy to answer any follow-up questions. Thank you so much.
Thank you very much, Ms. Carney. Mr. Ronholm, you are now recognized for 5 minutes. You may proceed.
Thank you, Chairman Bishop, Chairwoman DeLauro, Dr. Harris, subcommittee members. Thank you for the opportunity to testify today. When a root cause analysis of this crisis is conducted, there will be several issues that will be examined to determine the contributing factors. First and foremost, the actions of Abbott will need to be thoroughly reviewed, especially given the allegations contained in the whistleblower report. Another factor is what impact did market concentration have in causing this problem. However, I would like to focus my testimony on how the structure, governance, and performance of the FDA food program impacted the infant formula problem. A timeline of FDA's actions throughout the infant formula situation is attached as part of my testimony. As you will see, there are numerous questions that many of you in Congress have and many consumers have about whether FDA performed its regulatory role effectively. The evidence suggests that the agency was too slow to act, failed to take this issue seriously, and was not forthcoming with information to parents and caregivers. The infant formula crisis exposed a greater structure and culture problem that has long existed at FDA. This was merely one symptom of the overall problem, and it is clear that confidence in the food program at FDA is eroding. A big reason for this is the food program has second-class status within FDA, and it's resulted in serious problems. The FDA also lacks a single, full-time, fully empowered expert leader of all aspects of the food program. As you know, in recent decades, most FDA commissioners have been medical specialists who naturally focus on the programs impacting medical products. This is certainly warranted considering the impact these programs have on public health, and the pandemic is a perfect example of this. However, this usually results in intense competition for the commissioner's time and support, and focus on the food program is typically what has suffered under this dynamic. It has become impossible for an FDA commissioner to possess the bandwidth to provide leadership and accountability to a set of offices that regulate 80% of our food supply. It is this fragmented structure that led an unprecedented coalition of consumer groups, industry trade associations, and state and local regulators to join together recently to call on FDA to unify the food program under a deputy commissioner for foods. This position would have accountability to the commissioner and direct line authority over CFSAN, CBM, and the food-related operations of ORA. This would bring focused leadership and accountability to the food program. The current fragmented structure of the food program results in delays in making compliance decisions, including recalls. Congress and the HHS Inspector General should investigate how this fragmented structure and leadership affected its response to the Abbott infant formula problem. Perhaps sensing this frustration, Dr. Califf recently announced the appointment of Dr. Janet Woodcock, FDA's principal deputy commissioner, to oversee several parts of the FDA, including the major food program offices. This is another issue where consumer groups and industry agree. This move is disappointing and needs reconsideration. Dr. Woodcock's extensive FDA career has focused on policies impacting medical products, but she has no notable food policy credentials. Plus, this new arrangement provides no integration or accountability and no expert leader. It virtually ensures that the food program will continue to have second-class status. Another area where there are serious questions is how funding is allocated within the FDA food program. This is an issue that Chairwoman DeLauro and Chairman Bishop have led in seeking these answers. ORA, which is responsible for inspections and compliance, receives approximately 70% of all FDA food program funding. And despite the funding increases Congress has provided, ORA's domestic food inspections have declined in the years following the enactment of the Food Safety Modernization Act and before the pandemic shutdown. So the question this subcommittee needs to be asking about ORA are, how does ORA allocate food program funding? And is ORA making the best use of these resources? We are fortunate to have a person with immense expertise and abilities like Dr. Califf serving as FDA Commissioner. His recent testimony about investing in technology to leverage oversight activities certainly makes sense. However, investing in technologies and implementing structural changes for better governance are not mutually exclusive opportunities. We are not going to algorithm our way out of the existing problems in the FDA food program. We also need structural changes and stronger leadership that places a greater emphasis on food policy. Thank you for the opportunity to testify today and look forward to your questions.
Thank you, Mr. Ronholm. We will now proceed with questions. As I mentioned earlier, we will begin with the chair and ranking member, then alternating majority and minority with members present at the time the hearing started in order of seniority. Following that, I will recognize members not present at the time the hearing was called to order in their order of arrival. Each member will have 5 minutes in each round, so please be mindful of your time. I will now recognize myself for questions. Let me start with you, Mr. Ronholm. In your testimony, you indicated a successful foods program at FDA requires transparency and engagement from the agency. And you mentioned the recent announcement that Dr. Woodcock would be providing strategic counsel that seeks to improve coordination and transparency of food operations at FDA. However, this move does not reinstitute the position of Deputy Commissioner of Foods, which provide a direct line of authority over the food and regulatory activities at FDA. You suggest that part of the solution to improve the foods inside of SDA is to reinstate the position of Deputy Commissioner of Foods, and we'll certainly look into doing that. In the interim, given your expertise and familiarity with FDA, are there other changes that could be made to improve transparency and accountability to help rebuild confidence following the recent criticism of FDA?
Thank you, Mr. Chairman. Reinstating, I would just note that reinstating the Deputy Commissioner for Foods position would not require congressional action. Dr. Califf could certainly make that announcement at any time of making this move. But setting that point aside, I would just say that because ORA's human food inspection operations reports directly to the commissioner instead of a food policy leader, that means there's no single FDA official whose job it is to lead the food mission area and provide effective oversight to the program as a whole. So if this fragmented structure is meant to succeed, information on budget, planning, and program information must be widely shared to managers across the program, and decision roles must be clear. Also, accountability for how resources are used must be in place. So this means CFSAN and the Office of Food Policy and Response should have full access to all ORA budget planning and budget implementation data related to the human food program. It also means that CFSAN and the Office of Food Policy and Response should have full access to all ORA operational data related to inspection, lab analysis, and state partnerships. So again, as a result of this fragmented structure, there needs to be that increased coordination and accountability to make it more effective.
Thank you. Ms. Chamberlain, thank you so much for your testimony. It was very moving. I'm glad we were able to highlight your family's story. For those with rare medical conditions, formula is life-sustaining. I know you've been an advocate for many years, and I imagine it felt difficult to say everything in just 5 minutes. So is there anything additional that you'd like to add?
Thank you, Chairman Bishop, and thank you for your co-sponsorship of the MNEA. I have two quick things. Since the onset of COVID, there's been sort of an in-joke in people who advocate for rare disease that COVID taught the rest of the world what it was like to have a rare disease. So many people were sick. We had no idea what was going on for a while. We had no diagnosis. We had no treatments. We still have no cure. And we were confined to our homes and isolated. But that crisis spurred good things. There was remarkable support from our government and innovation in our scientific community. And I feel much the same about the formula crisis. So many people now understand how vital the white powder in these cans is to so many. And I'm hopeful that those of us who rely on this lifelong will have the attention and the support of both the public and our government in supporting the MNEA. Now that people understand us, we need them to take action.
Thank you very much. Mr. Carney, thank you for your testimony. Can you talk about some of the possible short-term concerns that you mentioned, hospitalizations, and that there perhaps a number of short and long-term impacts with medical outcomes and nutrition security. Can you talk about some of the short-term concerns and long-term? And the risk of making formula, diluting formula, to try to make it last longer? My time has almost expired.
Okay, I will be quick. Yes, I think we need to make sure that parents know that this, as we've said today, this crisis will be going on for several more weeks. So we need to be prepared. I would want to warn parents not to make homemade formulas. The American Academy of Pediatrics warns against that, as well as they should not dilute the formula, as both of these situations can lead to disastrous results and lead possibly to hospital admissions. They should check with their pediatricians or even a registered dietitian that specializes in pediatrics for guidance on proper substitutions.
Thank you. My time has expired. And at this time, I will yield to the distinguished ranking member, Dr. Harris, for your questions. Dr. Harris, you're recognized for 5 minutes.
Thank you very much, Mr. Chairman. I want to thank all the experts here today. Ms. Carney, let me ask, I'm hearing that some hospitals are having admissions through the emergency room. Parents can't find formula, or I don't know, maybe even some infants are getting ill because they don't have the formula they need. Is this happening nationwide, or how would we know if that's happening and the extent to which that's happening?
Well, certainly that we've heard of infants and older children too being admitted to the hospital when they try to substitute formulas or they make their own formula. As I referred to in my testimony, here in Memphis, we had two children, I believe they were older children with short bowel syndrome that were admitted to the hospital because of intolerance to the formula. They needed an elemental formula and they went to something that they could, just anything they could find. And since they were not able to absorb it, they had severe diarrhea and got severely dehydrated.
Yeah, so there's obviously some risk from this formula shortage that doesn't have to do with contamination. It has to do with the result of not having formula. So, Mr. Ronholm, let me ask you specifically, because in your timeline you don't mention the CDC and state agencies looking at the Chronobacter cases, because Chronobacter is ubiquitous. I mean, it's all over. That CDC could not find a link. CDC could not find a link between the Chronobacter that was found in the Abbott plant and the Chronobacter that infected that children. In fact, one of the cases, it was found in the distilled water that was used to mix the Chronobacter is found in the distilled water used to mix the formula. So given that, is there some concern that that this should have been resolved a lot earlier? I mean, they could have investigated this a lot earlier and started reopening the plant earlier when there was no direct linkage between the Chronobacter at the Abbott plant, again, something that's ubiquitous, and the Chronobacter that caused these, the tragic infections, 2 of which, of course, led to death, but none of them genetically the Chronobacter that was in the Abbott plant.
Thank you, Dr. Harris. So the timeline that we put together was focused exclusively on FDA actions, so we didn't incorporate CDC and state actions. Just in terms of making that link with the Abbott plan, I think we probably need to be a little careful just in terms of the small sample size. I think that was taken during that testing process and trying to make that link with the Abbott facility. You're absolutely correct that at this point there's no direct link, but I would just say that if you're taking a small sample size, I think it makes it more difficult to make that link. So if you were to imagine a barrel full of Lego pieces and you grab one handful, but it doesn't include a red piece, so you conclude that the tub must not contain a red one. Well, so I mean, it's highly unlikely that would be the case, but that's just an example that we just have to be careful about making that definitive conclusion that there is no link, because I think a lot of it has to do with what happened with the testing at the Sturgis facility.
Sure. So let me just follow up one thing that you mentioned in your testimony, and it goes a little beyond your testimony actually. Look, when the FDA was set up, we were in a much different world. The drug industry and the need to have a high level of expertise in drugs kind of distracts the FDA from the food aspect of it. Is it time to split the two apart, and not to split the two within the FDA, but to split them into 2 separate agencies, one of which deals with pharmaceuticals and one of which deals with food safety?
I think that idea, Dr. Harris, deserves a lot of attention and merit. I know it's something that Chairwoman DeLauro has been focused on for years, and that splitting out the food safety functions of the agency as it exists now and creating a separate agency while still remaining under the HHS umbrella. That certainly would be, I think, an effective approach that would get to the issues that I think everyone has become aware of during this crisis. Absolutely.
Yeah, and of course that'll take statutory action. I mean, we'd have to do that. In the meanwhile, what qualifications should the person at the FDA who will now be put in charge of food, what qualifications should they have?
Yeah, so right now, I think as an interim step before we can get to that point where you're taking food safety out of the FDA, I think what we need is an empowered deputy commissioner position that that holds food programs accountable, has oversight authority, and I think that person needs to have strong, deep food policy credentials, decades of experience in the food policy, whether it's industry, consumer groups, et cetera. There needs to be somebody who is steeped in food policy that can understand the intricacies, the nuance, to be able to develop policies, to react, to focus on illness prevention and react to crisis like this. I mean, I think today what happened at the other committee hearing, they couldn't decide whether 3 or 4 people should testify on this crisis. If you have one person leading the whole program, all Congress has to worry about is inviting one person to testify and hold that person accountable.
Thank you very much, and I yield back, Mr. Chairman.
Mr. Chairman, you're on mute.
I'm sorry. Thank you. And Dr. Harris, thank you for your questions. At this time, I'd like to yield to the chairwoman, Ms. DeLauro, who's been very tenacious, aggressive, and unyielding in getting to the bottom of this crisis. And Chairwoman DeLauro, you are now recognized for your questions for 5 minutes.
Thank you so much, Mr. Chairman. And I'm just very interested in the exchange between Dr. Harris and Mr. Ronholm, because in fact, I've recommended, and Senator Durbin has as well, for many years, an independent food safety agency, because when we get into these crises, not unlike what happened today at the prior committee meeting, no one is in charge. No one individual is in charge of food safety where the responsibility lies. In the interim, I think that Mr. Ronholm has laid out a structure because we know that it takes a while to get to where we want to go. But eventually, single food safety agency. We now have 15 agencies at the federal level who deal with some form of food safety. The principal ones are USDA and FDA. It should be one single agency. Mr. Ronholm, October, the report, the FDA received a report from a worker from the Abbott manufacturing facility in Michigan, unveiling a damning list of allegations: falsification of records, testing steals on empty cans, releasing untested infant formula, to name a few. Have you read the whistleblower report? And then as a food safety, thank you. As a food safety expert, what was the allegation that you found alarming?
The most alarming allegation in the report that I found would be the falsification of records. Now, falsifying records doesn't necessarily represent an immediate food safety threat in and of itself, but what it does reflect is the lack of a strong food safety culture at the facility, and that points to a much deeper problem that exists both at the facility and within the corporation. So when you have that level of a food safety culture problem, it results in things like gloating about hiding information from the FDA and other more immediate food safety threats like releasing the untested products, the unsanitary conditions at the plant, and failure to take corrective actions. And you think of the other things that falsifying information that can lead to, such as making it difficult to recall bad products. It would be difficult to trace where and what communities were affected by a particular recall if the records have been falsified or not available. There would be no way to look back at fixing problems that have been identified in the past. So you have all of this, you have all of these activities, all of these important actions that plants take tied to falsifying records. So that to me is a major red flag of how a bad food safety culture can permeate an organization.
Mm-hmm. Quite frankly, I wish Dr. Califf, when I asked him that question, had a similar answer, or at least had an answer to that issue. Dr. Carney, my opening remarks on Monday, I did a roundtable event with community organizations, Mothers on Infant Formula. I mentioned the grandmother brought 2 of her grandchildren to the emergency room experiencing vomiting and diarrhea. Later, the grandmother realized that the formula she was giving her grandchildren were part of the recall. A couple of quick questions. Currently, Chronobacter is not a reportable disease. Does that contribute to the issue of tracking?
Thank you so much, Ms. DeLauro. I don't know if that is an issue of tracking. I think it is, yeah, because it is not a diagnosed disease. And the only way we would know is if somebody was admitted for those different symptoms that you've just described, is to look at what they were, look at their condition, look at what they had consumed, and knowing what formula or feeding had been recommended for them. So we have to know if formula is contaminated before it gets to the children. We cannot let that happen and then try to diagnose that in the emergency room or in the hospital somewhere, so that it can be correct. So we don't ever give it to them and make sure that they're getting clean, safe formula and feedings.
Okay, I'm going to run out of time, Dr. Carney. Should it be a reportable disease? Let me just ask you for a yes or no. Should it be a reportable disease?
I think we have to report it so that we can track it and we can document it.
Brian, I have legislation, by the way, that I talked about, which will make it a reportable disease. The other thing is, because of this, of trying to track the cases, which you mentioned before, we had 2 infants who died, 4 others hospitalized. Do you think there's any underreporting of this because we don't have a tracking system? And it got to be brief because I've got 10 seconds.
I'm sorry, Rosa, was that directed at me?
It's going to go to Dr. Carney, but let me, Brian, Mr. Ronholm. Mm-hmm. Somebody.
I'm sorry, I missed the question.
All right, we'll perhaps come back to it, Mr. Lara. Your time has expired, and I will now recognize the gentleman from California, Mr. Valadeo, for 5 minutes. You are now recognized, Mr. Valadeo.
Thank you, Mr. Chairman. Thank you to all of our witnesses for your willingness to testify in front of the subcommittee today and share your perspective of the ongoing infant crisis. Less than 1 week ago, Food and Drug Administration Commissioner testified in front of this committee as well. There's still much that is unknown. It was more than discouraging to see he was unable to answer questions related to timing, causes, accountability, and more. It is unacceptable. We need a formula on our shelves yesterday, and we need real answers from our officials so we can ensure this never happens again. Just yesterday, I was in the grocery store in my district and noticed a lack of formula on the shelves. Instead, there were pieces of paper with a picture of the formula and a note instructing the customer to take the paper to the cashier to purchase. I'm not sure what their exact inventory is, but it did not look promising, unfortunately. It's almost June now. The recall was in February, and how are families in rural communities supposed to provide food for their babies that rely on this product, especially those who participate in the WIC program or do not have the means to drive all over the region looking for a specific type of formula. Thank you all again for your participation and continuing the conversation as we wait for the FDA and Abbott Nutrition to get the Sturgis facility back up in production. The FDA provided a response yesterday to a letter I sent earlier this month, along with my colleagues, related to the infant formula shortage. In this letter, they claim that the FDA began alerting federal partners and stakeholders about the potential supply disruptions even before Abbott voluntarily recalled the product. It seems an advance alert like this could have been better prepared or could have better prepared stakeholders for the formula shortage disruptions. Mr. Gay, were you notified about the forthcoming formula shortage by the FDA, USDA, a manufacturer? If so, when?
Thanks for your question. We were, but it was very late, probably just a few weeks before it really hit the news. Our warehouse tried to procure, obviously, different things, but the bigger issue for our store particularly is that in a rural area such as ours, probably 85–90% of my formula is WIC formula, which is just down to one type of formula. So even like today, for example, or my truck Monday, I got about 20 cases of Gerber formula in of different varieties, but that's not approved on WIC. And the Georgia WIC office just approved some substitutions for formulas that were on, subscribed by the doctor with the contract formula. So therein lies the problem: is there's no easy way to substitute that for the customer. And so even if you had advanced knowledge of it, there's no way to go around whatever your customers, and especially specifically in our areas, would be able to buy.
So you were given about a 2-week heads up, sounds like. And then in your testimony, you provide recommendations for the WIC program that you feel would improve the process for both WIC retailers and participants. Have you expressed these concerns to the WIC program officials? And if so, how have those concerns and recommendations have been received? And what kind of feedback have you heard?
Well, unfortunately for us, Georgia will be probably the last remaining state to not be EWIC approved. So we're still actually taking paper vouchers, which has made the process doubly hard because it's not a matter of just substituting UPCs. You have to physically go back to the WIC office and have your WICs changed. So we have, obviously addressed those before. Even in our area, hurricanes are a thing with similar things, and we very rarely get any real guidance or any help, so to speak, from the WIC offices here. It's mainly, it falls basically to us to handle kind of the best we can our customers and that.
I appreciate the prescription, the paper prescription one in your testimony is one that blew my mind. I was totally surprised by that one, but I appreciate you expressing that one. That's something we do need to look into more. And then Ms. Carney, as of last week's FDA hearing, I expressed concerns with the commissioner about Dr. Janet Woodcott becoming principal deputy commissioner due to her lack of expertise in food policy. I was not reassured with the response I received and still have those concerns. In his testimony, Mr. Ronholm expressed a similar concern with this action and potential consequences this decision will have on food policy under leadership. Ms. Carney, given your expertise and line of work, I'm curious about your opinion on this decision Do you agree with the concerns that Dr. Woodcock is not the best suited for this position and that the FDA should have someone with adequate expertise of food policy in this role?
I don't know if I can speak directly to that. I'm not really familiar with the person in charge, but I will say that we do have to have somebody that's competent and understands the repercussions of giving babies and children unsafe formula in food.
All right. Thank you. And my time has expired, so I yield back.
Thank you, Mr. Valadeo. And at this time, I'm delighted to recognize the gentlelady from Maine, Ms. Pingree. Ms. Pingree, you are now recognized for 5 minutes for your questions.
Thank you so much, Mr. Chair, and thank you for holding this hearing, and to my colleagues for their questions in the panel for all you're talking to us about. Mr. Ronholm, you've already provided us with such great information, and I appreciate the work you've done on this and the role Consumer Reports plays in making sure consumers have this important information. You've already talked a lot about how changing the agency, maybe a single agency, could make all the difference in a different leadership structure. Is there anything else you want to add on information sharing, leadership structure that we should consider as we think about how restructuring would work?
Yeah, I mean, I think the leadership component of this is the key. I mean, I think we really need to have that one single person in charge of the food program to be able to have that expertise, to have that oversight authority of the food programs, to be able to respond to these types of situations. I think one thing that I also mentioned was that if this fragmented structure is going to go forward, you must have information sharing between ORA, the Office of Regulatory Affairs, which is in charge of the inspection and compliance piece for FDA as well, and allow them to share that information and work plans with CFSAN, CVM, and the Office of Food Policy and Response. Without this type of information sharing, without this type of collaboration, I think we're going to continue to see what we're seeing now, just this kind of fragmented structure and how it leads to these types of crises. There's a running joke in the food policy world that the F is silent, in FDA, and the F only roars when there's a crisis like this. And I think you need that type of collaboration within the agency.
Yeah, I totally agree. And thank you for that. I think it's something we've all been talking about for a long time, and that I think there could be a bipartisan agreement on how to go about doing that. I want to take up a slightly different topic than just how the agency worked. And Ms. Chamberlain, you actually mentioned this about how the pandemic really got us thinking about a whole variety of different things. And now this has really helped people to understand formula, particularly those formulas that are medically necessary. I'm always interested in nutrition, diet, and health, and this fits right into that. And I've been a co-sponsor of the Medical Nutrition Equity Act, which would ensure a baseline of insurance coverage. So between you and Ms. Carney, could you talk a little bit about, I think people don't really understand the insurance challenges, the costs, and the lack of availability to those people who need this.
Yes, thank you. And thank you for your co-sponsorship. It's very important to so many. So my daughter is just over 4 feet tall, and she weighs about 62 pounds, and her formula is billed out at almost $1,600 a month to her insurance. And that's an amount that will increase, with weight and age. And she will be on that her entire life. The way that insurance reimbursement for medical nutrition is structured is state-based. And so one state may cover a child up to age 1, one state may cover up to age 5. You may only get coverage for PKU, but not tyrosinemia, just because that wasn't written into the law. There's, it's age, disorder, gender, type of insurance, income, and then anyone who's on a self-insured plan will not be bound by any state law. So that plan will not be bound by any requirements to cover medical foods. They can do it, but they don't have to. And so
go ahead. Yeah.
I was just going to say, you have a huge number of people who slip through all those loopholes. And what the MNEA does was just, for those people, we'll provide that federal floor. This is their medical treatment for life. And it just, it guarantees that they can continue to thrive.
Yeah, and thank you. And thanks for using your personal knowledge of your daughter's challenges and informing us of all of that. And Ms. Carney, I don't have a lot of time left, but we can see how important it is to have a federal standard here, but you must experience this all the time when families are challenged by insurance rules. You're muted, I think.
Thank you so much. Yes, absolutely. And registered dietitians are so important in working with families like Ms. Chamberlain is describing, all kinds of children that need different formulas, different diets. And another Medical Nutrition Therapy Act is up for discussion that would allow dietitians to provide specialized nutrition to the families and patients that are in need of these special formulas.
Thank you. Thank you, Mr. Chair. I yield back.
Thank you. At this time, I'm delighted to yield to the gentlelady from Louisiana, Ms. Letlow. Ms. Letlow, you are now recognized for 5 minutes for your questions.
Thank you, Chairman Bishop and Dr. Harris. I join my colleagues on the subcommittee in expressing my sincere gratitude to all our witnesses with us today. Just last week, the Food and Drug Administration Commissioner, Dr. Califf, testified before this subcommittee as one of his first official visits to Congress since the start of this crisis. And while it was past time for answers and a solution, we were still left with grave uncertainty with no clear end to this shortage in sight. As a mother of a 4-year-old and 2-year-old, I cannot imagine the sheer terror families must be experiencing as they desperately search to find the most basic life-sustaining nourishment for their children. As stated in my remarks to Dr. Califf, it was not too long ago that I myself was completely dependent on formula to fulfill my children's nutritional needs. In many cases, not all formulas are the same. Families know the specific brands and types of formula that work best for their children, and access to these essential goods simply should never be compromised. In part of my questioning, I asked Dr. Califf how much formula FDA expects will be imported under the new enforcement discretion guidance, and what is the real timeline of seeing those products on our store shelves. His answer was, it will gradually get better. Unfortunately, many of our constituents have encountered empty shelves for 3 weeks now, and it's time we seek solutions to address the shortage expeditiously and establish safeguards should our domestic supply ever be threatened again. Ms. Carney, as heartbreaking as it is to hear the personal stories you've shared, thank you for shedding some light on the true crisis families are facing and for your dedicated work as a nutritionist to provide care to your most critical patients during this time. As you and Ms. Chamberlain both mentioned in your testimonies, families and healthcare providers took it upon themselves soon after the closure of the Abbott facility to introduce new formula mixes to sustain for their children's daily nutritional needs. Maybe at the time it was for precautionary reasons, but it's now a reality. Through this committee's work in funding our federal agencies, the FDA just received a $102 million budget increase, including an $11 million increase specifically for maternal and infant health and nutrition for fiscal year 2022. Having provided the necessary resources, how could the FDA work more collaboratively with manufacturers and healthcare providers to address disruption in the supply chain and avoid this unprecedented shortage?
Sure. Thank you so much for that question. I think that we have to stay on top of the supply chain. I am in a hospital, and when our supplies get low, we scramble to find the right substitute, or not even substitute, but a good alternative to feed our patients and keep them nutritionally sound. We need communication. We need accountability, and we need to know what is available that we can give to our patients so that they don't suffer some of these things that I described in my testimony.
Sure. Thank you. And to follow up to that, given that Abbott is the only producer of some specialty metabolic formulas, from a healthcare perspective, do you believe there's a role providers could play in working with the industry and FDA to ensure additional options for therapeutic formulas remain available when the main source is at risk?
Yeah, for sure. We need alternative sources, and we need to look to other places that might produce this formula, manufacture some formulas. I don't think there needs to be a monopoly by one company in these specialty formulas. because as Ms. Chamberlain has described, her daughter, when they're out of that formula, that's the only thing she can take. So with the help of dietitians, we can help figure out some other dietary things that she can do to keep her daughter thriving and growing, but it causes a lot of distress, of course, and so we need other options and other sources besides one company. It just shouldn't be that way.
Sure. Mr. Gay, I represent a heavily rural district where the proximity and availability of retailers with certain goods is limited. And given your background as a rural retailer, I'm sure you understand how important these stores are to our local communities. Can you share with the subcommittee how this shortage has not only affected your store, but most importantly, your customers? And secondly, I believe retailers can play a vital role in the distribution of essential products. What additional steps have you taken to overcome these supply challenges to make sure infant formula is restocked, especially in our rural communities?
Thanks for the question. Yes, this the nearest big box retailer, so to speak, from any direction of my store is probably 25 to 30 minutes. And like I said, a lot of our formula, 90% of it is probably sold just on WIC. So it becomes a big problem that people can't leave to go get anything else. And as far as this specific formula thing has been much different than any of the other pandemic stuff. There were times when some of the bigger box retailers were getting items that I couldn't get or weren't getting my fair allocation of. I've talked to some warehouses, and this is not one of those situations. Everyone is getting their fair share of formula now. So I say that to say this: if there were times when my customers needed something and I could get it from somewhere else, I go get it, whether we sell it at what we paid for it or not make any money on it, just so they don't have to leave the community. This is one of those times where I don't have the ability to go get it from anywhere else. This solely falls back to a shortage with the oversight not getting that plant back open fast enough.
All right. Thank you so
Mr.
much.
Gay. Thank you, Ms. Ledlow. I believe your time has expired. And at this time, I am pleased to recognize the gentleman from Wisconsin, Mr. Pocan. Mr. Pocan, you are now recognized for 5 minutes for your questions.
Thank you very much, Mr. Chairman, and thanks for having this is in many ways the second hearing on this subject in 2 weeks, which is showing, again, I think Congress responding quickly like we did in the House, passed a bill, the president doing the Defense Production Act. Clearly, there were problems at the FDA, and we've had a great conversation about that this morning. But I think there may be some other concerns we should also talk about a little bit. I just want to start with Ms. Chamberlain. I just want to let you know your advocacy today. You've just got a new sponsor on that bill. I was texting my office, and we called up Jim McGovern's office, and we're on it. So just want to let you know your time has been well spent, and thank you for informing me. And as other members may ask the question, I'll also refer them to that bill. So thank you for your time today. I do want to ask a question of Mr. Ronholm. What you started to say, well, we're not going to, I won't start with the monopoly problems. I'll talk about the FDA. And I think we've talked a lot about the FDA. I think, though, even we do have to fix the FDA situation on this, and I think we can do it in a bipartisan way. There's still a problem when 4 companies are producing 90% of the product, right? And we know what that means. Often consumers are going to get a raw deal, perhaps on the paying out for it from things like right now, when someone goes down who's got these exclusivity contracts through WIC. So I guess my questions are, one, how has sole sourced WIC contracts impacted parents during the infant formula shortage? So trying to get to this monopoly issue. Second, should we be considering any changes in Congress, either in the appropriations process or the next farm bill to address this? And then third, should we be allowing this monopoly structure that states are using our WIC federal dollars to then have these monopoly relationships? Because to me, that may be part of the problem.
Yeah, those are all very critical questions, Mr. Pocan, and I think you certainly, your point is well taken in terms of 4 companies that control 90% of the market, and only 3 of them actually bid on WIC rebate contracts. So, and Abbott is by far the largest one, and I believe they have contracts for in 30 or 31 states. I think it was the latest figure. So when those contracts come up, it these companies submit based on their ability to meet the demand in a particular state, and Abbott is usually the only one that's big enough to do that. And I think, we mentioned that they have a large part of the market. I think when it comes to the WIC market, they have approximately 55 to 60% of the WIC market. So that's a significant size of the market that really needs to be examined on. So when situations like this hit, how does it impact that particular? And it's obviously going to have a bigger impact because these companies use the WIC market to get into the overall non-WIC market to even increase the share of their market. So that creates further shortage problems. In terms of your question about what Congress can do in terms of fixing FDA, I think this is going to be a several-step process. The first step that the FDA can take is to appoint that empowered deputy commissioner, expert leader that could provide the leadership and accountability in the foods program, be that single person in charge to hold the agency accountable. The next step is to maybe consider legislation that Chairwoman DeLauro and Dr. Harris had discussed about splitting the food part of the FDA and creating a separate agency while still under the HHS umbrella. And the third ultimate step in long term is ultimately creating this independent food safety agency, much like the EPA.
So let me just ask though, none of those actually address the monopoly issue, right? So I understand the FDA side. I think that's been well talked about, but how about this monopoly side? Are we actually creating a bigger problem by allowing WIC dollars to be used in the way they currently are? Because we've really now made it's not just a monopoly of the three companies bidding, but like you said, it's really one company that's left out there.
Yeah, it's absolutely a problem when that one company can control that much of the market. I'm not the market concentration expert, FTC expert, but certainly anyone can identify this as an issue that needs to be addressed for certain.
Great, thank you. And very quickly, Mr. Gay, if you can do it in like 20 seconds or less, I got 28 seconds. How does your store making purchase decisions about formula impacted by WIC?
It's huge. Like I said, with it being 90% of the thing, we basically only carry WIC formula. And so, whatever they use, we carry that almost exclusively.
Gotcha. I yield back, Mr. Chairman. Thank you very much.
Thank you very much, Mr. Pocan. And at this time, I am pleased to yield to the gentlelady from Illinois, Ms. Underwood. You are now recognized for 5 minutes, Ms. Underwood.
Well, thank you, Mr. Chairman. I want to begin today by acknowledging just how terrifying our nation's infant formula shortage is for parents and how urgent our response must be from the administration, from formula manufacturers, retailers, and all other stakeholders. We need an all hands on deck response until every family has access to the safe formula they need. We also need to be thinking more broadly about what this crisis says about our nation's support system for growing families. While the current infant formula shortage is unique, it's a symptom of long-term policy failures to prioritize the nutrition needs of infants. This is happening in a country with a glaring lack of sufficient support for breastfeeding, in a country with a higher maternal mortality rate than any other high-income nation, and in a country where even before the current shortage, low-income families struggle to access the nutrition their children need due to the highly concentrated infant formula market in which 4 companies make up approximately 90% of formula available, and the Special Supplemental Nutrition Program for Women, Infants, and Children, known as WIC, offers limited formula option for participating parents. Today's infant formula shortages are a symptom of both market failures and policy failures, and both issues must be addressed to not only get more formula onto shelves now, but also to prevent something like this from ever happening again, and to ensure that America is the most supportive place in the world to grow a family. Ms. Carney, how would a more robust support system for growing families in the United States, including support for breastfeeding, help parents access to the nutrition their infants need and address maternal and infant disparities?
Thank you, Ms. Underwood, for that question. I would love to address that. First of all, just a word about WIC and excuse me, and our supply of formula here at St. Jude. And we are so blessed here at St. Jude from our donors that we are able to give any formula, not based on WIC bids or anything that's that the WIC program has put the babies or children on before they arrive at St. Jude. So we do provide whatever formula our dietitians think are best for these children. To address your question, I do think in my work in public health in graduate school, we always looked at working upstream rather than downstream. So to find something that would promote public health before we are dealing with the problems. So instead of curing things, let's do prevention. And I always think that breastfeeding, well, we know that breastfeeding is optimal feeding for infants. So if we can think about upstream for a few minutes to answer your question and have more efforts to support moms and babies to successfully breastfeed, we're not looking at so much of the formula usage, and the children, the infants and children that do need formula, more would be available for them. I know
we also know, oh, go ahead.
Go ahead. Okay, I know that mothers face challenges, and they have to return to work and to school, and they don't get the support they need. So I think, us looking at ways to provide possibly more paid maternity leave after delivery of a baby and more support from lactation consultants like I am, so that they can successfully breastfeed will really help address this problem and increase breastfeeding rates in this country.
Yes, ma'am. Increasing access to lactation consultants and making sure that, we're avoiding moms and babies going hungry so that they can achieve their milestones and grow into healthy, thriving children is very important. Ms. Carney, federal agencies have released guidance on the current infant formula shortage, which includes a recommendation that parents contact their child's pediatrician if they have questions about safely providing the nutrition their infant needs. What about the parents of children who do not have a consistent pediatric health provider? Where can they turn to for guidance?
So if a child doesn't have a primary care provider, I would suggest they would check with their local WIC office who could guide them, and also the health department clinic in their community. And there you'll find pediatric registered dietitians to help them decide or to consult what is the best formula for them.
Thank you so much for providing that information. As a registered nurse, I know how important it is to share clear, accurate, and evidence-based information with patients to address their concerns and answer questions. Many of us do have these WIC offices in our communities. We all have health departments that are great resources for all of us to consult. And I would encourage the American people to be in touch. Thank you so much to our witnesses, and I yield back.
Thank you, Ms. Underwood. At this time, I yield to the gentlelady from California, the chair of the Foreign Ops Subcommittee of Appropriations. Ms. Lee, you are now recognized for 5 minutes.
Thank you very much, Mr. Chairman, and thank you, Ranking Member and members and witnesses for this very important hearing. For the life of me, initially when I heard about this baby formula shortage, I asked myself, how could this happen in the wealthiest and most powerful country in the world? Baby formula shortage. Unbelievable. Then I realized this is an example of what we call monopoly capitalism, where only 4 countries own actually 90% of the market. And so this has got to change just in terms of the structural issues, because if you don't have competition in a capitalist society, this is what happens. And so I'm just wondering if any of you kind of could, how you see this in terms of agencies, federal agencies working to address these unfair practices, because like stock buybacks, price gouging, all of the issues that led to this. I don't know if you're looking at how this happened structurally, but if you are, I'd like your take on that. And then secondly, with regard, and I guess Mr. Ronholm, this would be a question for you or Mr. Gay, in terms of WIC, and low-income and disadvantaged communities, of course, they're suffering tremendously from the consequences of this infant formula recall, having already disproportionately suffered from COVID-19 and the resulting economic pressures. And now with the new strategies to try to immediately bring formula to our children, our babies, what kind of hesitancy do you see, or do you see any hesitancy given the long history of medical racism in this country? Are WIC recipients, especially recipients of color, are they reluctant or resistant or questioning the efficacy and the safety of the formula that now will be available?
I guess I'll jump in on that one, Michael Gay. Great question. The biggest issue I think here, as far as hesitancy, is just like yesterday. Not only has Georgia WIC been slow to make a substitution, but especially younger mothers in general are very hesitant to even change formula for their baby, even though nutritionally and it may be the same quality and a fair swap. They are very hesitant and skittish to take their baby off of whatever they've talked about their doctor with feeding their child. So even though there may be, like we did get some a different national brand available, they walked out of the store and didn't buy anything because they were, you could tell they were a little hesitant to just to buy it because it wasn't what was on their WIC, even after telling them to go back to the WIC office and check with them. So there's definitely an issue there with WIC and the way they handle formula.
Well, are we looking at outreach strategies? And I asked the other day in our prior hearing about this, and actually with the meeting with the White House, are there strategies that are, and we used some during COVID, to have trusted messengers, people that the communities can relate to, provide the information about the safety of the formulas that are coming in? Has anyone looked at that as it being important at this point, given the medical racism and hesitancy we have in many of our communities?
Honestly, man, the first email I received about using different formulas was Monday of this week from WIC. Other than that, we've heard zero from our WIC office as to how to proceed. It more as a, we just kind of do the best we can at the store level to provide, and but we are not really given any direction from the WIC office at all.
Okay, Mr. Chairman, I think that's something we need to follow up with, because I know in many communities, this is an issue, as it was with regard to the vaccines and the COVID treatments and the outreach efforts and the real reluctance because of the history of what we know in terms of systemic racism in this country, in low income and minority communities. The other question, maybe Mr. Ronholm, can you is it Ronholm? Tell me what you think. Have any of your reports looked at how this monopoly can be broken up?
Yeah, I mean, it certainly has an impact, as Mr. Pocan alluded to as well. I think another big piece of this too that we can look at is, how can we work with the states in terms of fixing that system and changing that contract structure? Because FNS at USDA, they don't approve these WIC contracts. It's the states that do them. And so, how can we work with state partners in order to change that system? Can they break up those contracts where they're splitting them up by region to give other companies an opportunity to bid on them? Because when one company has the contract for 30 plus states, I mean, that's a pretty significant share, and that can have a big impact on supply when we face the situation. So if there's a way we could work with states to kind of figure out how to break those contracts up by region to give more companies an opportunity to make those bids, get into those markets, I think that might be an important step to consider.
Good idea.
Thank you, Ms. B. Your time has expired.
Thank you.
And at this time, I'm delighted to yield to the gentlelady from Minnesota, the chair of the Defense Subcommittee, Ms. McCollum. Ms. McCollum, you are now recognized for 5 minutes.
Thank you, Mr. Chair, and I'm glad you had a good night last night. Ms. Carney, I want to start with you. Thank you for your testimony. A member of the Academy of Nutrition and Dietetics from Minnesota recently shared personal experiences dealing with the infant formula crisis. She found parents desperate to feed their children getting conflicted information, often from unqualified people on social media were sharing misinformation, how to do home formula, ingredients using goat milk. And I saw some of that even before we had spoken with the dietitian myself. And then as many of my rural colleagues have pointed out, they don't often have registered dietitians and local staff at clinics and doctors, so they aren't necessarily familiar with formula option brands that they don't get. So my point is, the administration's working on its plans to address this, immediate formula shortage. But as Ms. Lee said, a horrible environment of mistrust has also been created. Maybe can you speak to a little bit about this environment of mistrust and what you think needs to be done in the future, and better ways to help WIC participants so they aren't, so disproportionately impacted by this. And a lot of this has been pointed out, it's federal and it's state. This is an opportunity for me, and I'm going to be doing it our sessions ending here in Minnesota for the state legislators, to reach out to my state legislators and talk about how we can be better partners on this and how we can streamline it and what may need to happen federally to do it. You just share some of your thoughts and experiences on this. And are the online media sites, is Twitter, is anybody helping? Is anybody recommending this is a safe site to go if you're looking for something to help your child?
Thank you for that question so much. Yes, I've seen the social media too. There it's rampant with homemade formula recipes and suggestions, and go get goat's milk or almond milk, like I mentioned in my testimony. And I also mentioned that the dietitian said that one of her clients told her, I don't think I want to get any formula that's on the shelf because it could all be contaminated. When is the next time I'm going to go reach for a formula? They're going to recall it and say, don't give it to your baby. So there's a huge mistrust feeling out there among all of our mothers and fathers and parents in the country, and we've got to address this. And I want to go back a minute when we're talking about what are we doing with the companies out here that have so much of the market share of our whole entire country for infant formula. And one thing that we really haven't talked about is the WHO code for marketing breast milk substitutes, and that's what these formulas are. They're breast milk substitutes. Right. So if we look at the WHO code, and other countries, other developed countries are abiding by the WHO code, and this gives guidelines for how companies can market their infant formulas in a safe way. So maybe we should go back to that and think about what is it about the WHO code that would benefit all of our families in the country so that they are assured when they do have to reach for infant formula, when breastfeeding cannot be an option or will not be an option, what are the things that are marketed directly to our families that tell them about the formula? There's a lot of confusion about that. So I did want to mention that too.
Thank you. Mr. Ronholm, anything you want to add on that? I mean, you're out there in the heartbeat of Consumer Reports, and you're watching consumers just get misled with bad information.
Yeah, absolutely, Congresswoman. The stories that we've been getting are very, very heartbreaking. You hear the desperation, and they're at a loss of what they can do, and of course, low-income WIC recipients have it especially tough when you consider that they don't have the resources to drive all around to try to find products. So, yeah, I mean, I don't think I can add anything more than what Ms. Carney had stated. It's just, again, it's just heartbreaking to hear the stories come in that we're compiling. I excerpted some of them as part of my testimony, and certainly it compels all of us to act.
So, Mr. Chair, I think I see an opportunity to communicate better with my state legislators. But I also see a failed opportunity for, quite frankly, our public media organizations to get the facts out, to get them right, whether it's news, radio, or whatever, or social media. We've been trying to do it the best we can on our website. These are our public airways. This is a public crisis, just as COVID was. And rather than just slice a news story in here and there without any follow-up, I just think it was a huge failure also for some of these companies that manufacture it not to put out public announcements. Thank you, Mr. Chair, for having this hearing, and let's hope you never have to have a hearing like this again.
Thank you, Ms. McCollum. At this time, I will recognize the gentlelady from Florida, the chair of the Military Construction Veterans Affairs Subcommittee, Ms. Wasserman Schultz, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. You know, the brutal truth is that 4 companies control nearly 90% of America's baby formula market, and that's the very definition of an oligopoly. This corporate consolidation hurts all of our families, but especially lower income workers. It's the same with greedy oil CEOs who keep energy supplies low and pump prices high, hurting those who do the real work. At the end of the day, we need to make sure that we have adequate supply and that we can keep children safe. And the Biden administration is doing all it can to fix this, from boosting supplies to importing massive shipments from Europe with Operation Fly Formula. But the long-term problem will not go away until we address corporate consolidation, improve WIC, and adopt sensible FDA safety standards. Now, the WIC program provides information on healthy eating and helps millions of families buy nutritious foods, including baby formula. Half of all US formula consumption goes through the WIC program, which provides free infant formula, as we've been talking about today, where states negotiate bulk discounts in exchange for market exclusivity. Now, I'll take you back to 1989, when Republican President George Bush enacted legislation requiring all state WIC programs to use competitive bidding for the purchase of infant formula. In practice, this means that the state of Florida, for example, is required to use a single supplier for the entire state's supply of WIC baby formula. The competitive bidding process has yielded $1.3 billion to $2 billion a year in savings, and allowing WIC to serve about 2 million more participants annually because of the discounts. However, when there's a supply shock caused by one of the 4 market participants, like what happened with Abbott in this case, it creates a serious risk to infant health across the country. And that problem is further exacerbated when the interests of private monopolists are put ahead of American families. Now, you may remember when the Trump administration actually threatened countries with trade sanctions and withdrawal of military aid if they supported an international resolution in support of breastfeeding as a healthy option for infants. I mean, that is completely outrageous. So my question is the first question is to Mr. Ronholm. We need to find a long-term solution for this problem that's caused by a monopolized industry. Can you explain for us really how the single source contracting for WIC baby formula might have contributed to consolidation in the industry?
Thank you, Congresswoman. Yeah, no, absolutely. So I think, as you rightly pointed out, when you have only these sole source contracts, what ends up happening is, companies assess their ability to meet the demand for these particular contracts and place those bids. And right now, as we've discussed, there's only 3 companies that do that right now. And Abbott being the largest one, because they have that ability, they have the infrastructure to meet the demand in a particular state, especially larger population ones. And as a result, you only see them in 30 plus states. And to your point about supply shock, so when we're faced with these types of situations, it makes it more difficult for these other companies to refill the market share, that the supply that's lost for these supply shocks, because they may not be as big as these companies, as Abbott, and so they may not have the infrastructure to ramp up production quickly enough to get to that point where we can refill that supply. So yeah, I mean, this certainly is an issue that deserves careful examination. How do those contracts get broken up where you allow for multiple bidders to minimize any supply shock should it happen?
And why does the US market not support more competition in the baby formula industry outside of WIC sales? It certainly seems like there is a tremendous amount of desire and need out there.
It could be for any number of reasons, cost of entry to the market, the availability of limited supply ingredients, the cost of those supplies. So again, when you're faced with those market dynamics, it's only the kind of the larger players that are able to afford the ingredients that go into these products and to be able to produce them in the mass scale. That's not to say that applied in this particular situation specifically, but typically that's markets. That's what ends up happening.
And I want to just ask you really quickly, because we know that in Europe, they consistently produce a baby formula surplus. But there are rigid labeling and nutritional requirements for formula containers here in the US that the FDA requires. And they prohibit the sale of many European-made products, even though the formulas themselves meet FDA nutritional and purity standards. So what sort of policy changes would you like to see undertaken to ease restrictions on baby formula imports while still ensuring that the product meets our safety standards?
Yeah, I think it's critical that we maintain those safety standards that FDA has set on infant formula. That's absolutely critical. So there's a comfort level with consumers when they're able to purchase something that they know is an FDA inspected facility overseas. But to your point, sometimes these regulations, these really strict regulations are thinly disguised trade protection measures. And so, that's certainly an issue that we'd have to examine carefully to make sure that we can have that access.
Thank you, Ms. Wasserman-Schultz. I believe your time has expired. And at this time, I would like to yield to the gentlelady from New York, Ms. Ming. Ms. Ming, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. My question is for Mr. Ronholm. Consumer Reports published an article in March where your organization describes FOIA requests for FDA inspection reports in 2019, 2021, and 2022. These reports show that FDA had documented serious and ongoing safety concerns at Abbott's plant just as the outbreak emerged in March. These reports also reveal that Abbott received 17 consumer complaints between 2019 to 2021, including 15 complaints of infants having tested positive for another pathogen, Salmonella, and 1 complaint related to Chronobacter. I wanted to find out, relatively speaking, is the number of complaints about this product, for example, lower or higher compared to another product? And how many complaints, let's say, would raise the level to cause alarm? Or how can we ensure that the public is aware of these consumer complaints much earlier on in the process to allow consumers to make the most informed choices? FDA obviously reacted too slowly, and the company obviously did not reveal to the public the number of complaints that they had received.
Yeah, Ms. Bing, I don't have a specific frame of reference of what threshold for complaints, would trigger concern. I would say that I think overall 17 is a notable number, and I think it would certainly gain some attention at a federal agency, just based on my experience at USDA. And when you combine that with the inspection reports that FDA had of the Sturgis facility in the years that you mentioned, combine that with the consumer complaints, clearly there were some red flags there that needed to be addressed. And so the concern from the consumer standpoint is when all these complaints are being filed, you have these inspection reports that encounter the Salmonella test samples of Chronobacter, et cetera. That's cause for concern. That should be a sign to FDA that there's a problem at this particular facility. They need to set up shop there to figure out what the problem is.
So no, thank you. That's very helpful. And I know we've talked a lot about needed reform at the FDA, but on top of that, do you think there are things that we can require, let's say, of private companies when complaints are being made? I know there's not necessarily a framework of a minimum threshold or trigger level, but are there things that companies should be doing when they're receiving complaint over complaint of relatively serious illnesses resulting from their products?
Yeah, I think certainly companies, when they get these complaints, they should share them immediately with the FDA. I think what they also should be doing is sharing their test results, whatever the microbial test results that they take at their particular facilities. So when they take those samples, and if there's an issue, they need to share them with the FDA so that there can be some sort of record. So in the event that there is a problem, they have that ability to go back, see that this facility experienced the problem in the past and need to fix it. So I think as much information sharing as there can be between the company and the FDA certainly would be beneficial. Would it, prevent the situation altogether? That I think that would remain to be seen, but it certainly helps everyone get educated on precisely what the issues are at a particular facility. Absolutely.
Right. So if the FDA doesn't react appropriately, let's say there were 100 complaints to a business like Abbott, if the FDA hadn't done its due diligence and a company like Abbott doesn't reveal anything to the public, if there are 100, 200 complaints, that means they would keep selling this product and no one in the public would even know that complaints were being made, right?
That's right. And I think it also speaks to the question of the fragmented leadership at FDA. You had this major whistleblower report come in and, they didn't bother to share it with everybody within the agency, let alone react to it. So, that's certainly an issue as well.
Thank you. I yield back.
Thank you very much, Ms. Ming. I believe we have completed the round of questions. I understand that there are no more questions except for the chair lady, Mr. Laura, who I believe has one additional question. So I will at this time yield to Chairwoman DeLaura for your final question.
Well, just
I
I'll
now
be very,
yield
very
to
quick.
Mr. Laura.
Thank you. Very, very quick. First of all, I'd just say to my colleague, Congresswoman Meng, what the FDA needs to do is to understand that they are a regulatory agency and what that entails. We do not produce infant formula at the federal level. That's not our job. Our job is through the FDA is to be able to make sure that those who do produce it are held to a standard and to make sure that standard is adhered to. And if it isn't adhered to, that they need to they need to be accountable for that. The product should come off the market until we have a solution to it. Very, very quickly, because I just wanted to get the answer from you, Dr. Carney. If you could unmute. Because of the inability to track the cases, as you have mentioned, we know 2 infants died, 4 others were hospitalized. Do you think that there is underreporting because we do not have a tracking system so that there could be more cases out there?
Thank you, Chair Delario. And I'm not a doctor, so I appreciate that honor, but I'm a dietitian. I definitely agree with you that there is a problem if we cannot track that. We need to, and I know that we were just talking about informing the parents and out there in the public, but there are so many sick children already in hospitals. If we give them contaminated formula on top of their current illness, it would be devastating. So we've got to have some tracking and reporting on a consistent basis.
Right, right. So many of the women that I spoke to yesterday at the round table had a child. They took them to the emergency room, and then they came out of the emergency room, but then they looked at the product that they had, and it was a recalled product. So there's every likelihood that it could be connected. So thank you very much. And thank you so much, Mr. Chairman. Thank you for doing this hearing today. It really is a critical issue. Thanks.
Thank you, Mr. Laura. And let me say thank you again to our witnesses, Ms. Chamberlain, Mr. Gay, Ms. Carney, and Mr. Ronholm. We very much appreciate this discussion. Your testimony was powerful and informative. As we continue to look for answers and solutions to this crisis, it's important that you all have a voice. You are on the ground and you experience the consequences of something like this firsthand. Thank you also for the hard work that you do, from advocating for important policies to supporting your local communities. Dr. Harris, do you have any closing remarks?
Thank you, Mr. Chair. Just to say thank you to the witnesses today. Ms. Chamberlain, thank you very much for testifying. I know how incredibly difficult it must be for you and people who who have children with PKU to have this happen. And rest assured that we will do our best to make sure that it doesn't happen again, because we know that for some children, especially the infant formula is very, very essential. And again, thanks to all the witnesses today. Thank you, Mr. Chairman. I yield back.
Thank you, Dr. Harris, and thanks to all of the members who were in attendance And let me say a thank you to our staff who worked so hard to put this hearing together quickly. So thank you so much. And with that, this subcommittee is adjourned.